Good afternoon, everyone. I'm David Levitz from MobileODT. This is a company that I co-founded with Ardell Beery. We make low-cost imaging devices for cervical cancer detection. We make this device, the mobile colposcope, or the other system. This is a smartphone-based imaging system that you use to look at the cervix. I'll show it to you in a second. Essentially, cervical cancer is a real big problem in most of the developing world where there's no access to screening like HPV, DNA testing, or Pap results. Often, most of the testing is done through visualization with the naked eye. The patient comes in, lays on the table, they insert a speculum into the vagina, they put a thin layer of vinegar on the cervix, and they look to see if any area turned white. If an area turned white, then often they don't do a biopsy like Natalia said, but rather they do cryotherapy, and they kind of like removing a wart off your foot, and they remove about 1/3 of the cervix. And in order to support the nurses who are out there in the field who don't have access to biopsy or to Pap or HPV, we developed a tool that will improve the imaging, and that's this device. It's used to, it's a colposcope. You can take pictures, and it has green light visualization similar to colposcopy. The nurses who are doing the screening are still struggling, even with our device, to actually know who to treat and who not to treat. And so, in addition to these, in addition to this imaging system, we're trying to develop a suite of tools that will help support them in the field. So the purpose of my talk is to talk about one of these tools, and we didn't actually test it on this device, but rather in a clinic. So it is what we call polarization difference imaging, or PDI. It's very similar to, and was inspired by Jessica's PolCam work back 14, 15 years ago. As Natalia said, colposcopy is pretty sensitive. It's not that specific. There's also poor agreement between clinicians who do it. And that is very important. And it's difficult for, right now it's impossible for clinicians, even at the most advanced clinics, to determine which lesions are going to become precancer and cancer and which ones are going to regress. And so we're trying to use polarization methods to address this issue. To give you a simple overview, we shine polarized light on the tissue, and we detect both polarizations. Now, the light that's, as you know, that is polarized parallel to the incoming polarization will be from both the superficial layer and the deep layer, and the light that's orthogonal will come from the deep layer. When you take the difference, you can isolate that superficial layer. Oftentimes, people also scale this by dividing by the sum of the parallel and the orthogonal components, which we do sometimes as well, but not in this trial. So we actually modified a commercial device, a Welch Allyn colposcope, with a 3D printed case and a liquid crystal variable retarder to change the polarization state, and we took it into the clinic and imaged 8 patients. The protocol is that the patients were referred to colposcopy after an abnormal screening test. The cervix was visualized according to the standard of care. Acetic acid was applied as expected, and then the doctor acquired both normal and PDI images. This is our setup. The colposcopes are really old instruments. It's something that we've learned in trying to deal with them, is that a lot of the colposcopes in the clinic today actually use analog technology like S-video, so a frame grabber was needed because when we came into the clinic, our approach was that we wanted to change what the clinicians were doing as little as possible. So we actually stuck with our old instrument at the time. We realized later that actually building the colposcope from scratch was substantially easier than dealing with this analog stuff because it's just difficult to control. But essentially there was a monitor with a data acquisition program, and the clinician would just push a button and all the images would be captured at once. The liquid crystal variable retarder would change the polarization states from parallel to orthogonal for the 3 color channels. We have white light coming in, but red, green, and blue color channels each require a different driving voltage on the LCVR in order to have maximum and minimal light transmitting through it. So we acquired 6 images, one at each of the polarizations for the 3 color channels. And we used the 5th image to give the LCVR a little bit of time to relax. And just to show you, this is an image of a rotten potato with some nice surface structure. Just to figure out what voltages to drive the LCVR, we drove the LCVR various voltages, and we looked for the minima and the maximum, just to see. We didn't do this on the entire image because it took a very long time and it was too much data, but we identified the voltages that we needed, and we did this for the 3 color channels. Here are our data from a cervical image. We found out very quickly, which was actually been confirmed by Tatiana in one of the talks that I've heard her give. We tried imaging, and the red and blue images did not have the ideal information. We found that the blue was relatively noisy, and the red did not show that much clear information when we took the difference. And the best contrast we got in the green channel. So looking at the green channel, this is an image where there was some aceto whitening and some glare, and we see that the glare stayed, but the aceto whitening disappeared. And in contrast, when we looked at, there was no aceto whitening, the glare stayed. And this for us was a very interesting result because aceto whitening and glare are 2 things that our customers in the field are actually struggling to distinguish between. So that is essentially our key result. So if you look at a cervical image acquired from the field, this one's not ours, but you can see that aceto whitening is it's a different type of white than the glare. But for a nurse who has not that much education, oftentimes they have just a short course beyond high school about how to do this. It's difficult for them to tell this apart. So the way we sort of envision this is for there to be an additional light source and filter, so that you push it, just like you push this button and the image turns green, you'd push a button and you'd see the polarization, the PDI image, and then you could tell if there's an area that they need to treat or not to treat. Trying to dig a little bit into what this means. Aceto whitening is you take a long swab with acetic acid, 3 to 5%, and you apply it on the cervix. Within 1 to 5 minutes, there's a whitening effect. The tissue gets dehydrated and the chromatin gets condensed. And so the areas of increased proliferation where you have more DNA material actually turns white. There's also possible role for keratin, though I've seen some conflicting papers on the actual role. But our results suggest that the aceto white lesions depolarize the light very, very quickly. despite that the acetyl whitening reaches very superficially. To conclude, the images showed that either in colposcopy or during VIA procedures, we were able to use polarized light to distinguish between acetyl whitening and glare, and we believe that this has potential in the field. Some of the next steps is we're trying to put the technology on this device and integrate it both on the hardware, on the software, and the app, and eventually, if we want to really go a little further into this, we're going to try to do some further mural matrix imaging on the cervix. Because we funded the trial, I'm going to thank my co-founder and my team, and thank you all for listening.
So, question please?
Thank you, David, but the problem of standard colposcopy, it's not only low specificity, but it's very low coefficient of agreement.
Yes.
Are you going to compare your approach and standard colposcopy with estimation of these parameters?
Yes, this is right now happening at Scripps Clinic in San Diego in the US. We've acquired close to, the goal is to be 150 patients, and we are around 130-ish. In the US, you don't have as high patient volume as you do in other parts of the world, so the trial is progressing much slower than we'd hoped, but this is something that we are doing. And another thing that we're trying to do is we're trying to develop tools like automated machine learning that will be able to support the person in the field to say, you know, this is something that they should treat and this is something that they shouldn't treat. Because right now they need a lot more support than they have.
Any more questions?
Good luck.
Thank you.
Any more questions? Okay, so if you keep in mind the next question, so okay, we'll have some time after.